All right, good morning, everybody. Sorry for the late start. We were trying to knock out the Facebook stuff that was blocking us.
You're muted.
Okay, I think we're good to go now. I think after 7 times we'd have this right. All right, so we're going to talk about grief and loss today. I'm surrounded by chaplains and social workers, which they'll be the experts in the field here. So when we start with grief and loss, we need to understand kind of what we're dealing with, right? So as always with all these classes, the first thing we do is a self-assessment. What is our own experience with grief and loss, right? How has that affected us? The nurse I was going to ask permission to is not here, so I'll be vague. So the last couple of weeks, for the Air Force people, I've been a little hard on the Air Force people, but one of our lovely nurses shared with us her dad was in Vietnam as a helicopter rescue pilot. And so he would be flying into hot zones and picking people up. And the pertinent thing to grief and loss is that she said the only time she saw him cry was when he was expressing the loss of his door gunner in Vietnam 40 years ago. So as we talk through, one, not all Air Force people eat steak and hang out at the Air Force base. There's some pretty hardcore folks. 2, grief affects everybody differently. So self-assessments are important on how we can do it as a palliative care team, as a hospice team. And then also, as we get into a world where we get to interact with people from so many backgrounds, how does our background affect what we're looking at in front of us? How does their background affect how we interact? So we want to make sure that we all understand that. From a nurse's role, some of the things that we want to look at in assessment is facilitating the grief and loss. So again, this is an ELNEC course, but we're lucky enough to have chaplains and social workers in our course. So as we assess the grief, maybe I can ask I've put them at the table, but I haven't told them questions I'm going to ask. So this is going to be on the fly. So maybe from our expert core here in front of me, what is one thing that you assess when you're looking at grief and loss?
Support system.
Okay, what their support system is?
Mm-hmm.
Personal sense of spirituality.
Okay, from the chaplain's perspective, what is their spirituality?
One thing I look for is in talking about, if this is a pre-bereavement assessment, talking about the disease, how prepared they are.
We're going to get to that one. We're going to get to pre-bereavement in a sec. And
complicated. I mean, a pet just died and somebody else is that complicated grief thing.
So how many other things are complicating the grief that's in front of us? Okay. So when we're supporting the survivor, we want them to be able to allow them to feel the loss if that's what they want to do, right? Grief is individual. Express the loss if they can and be that listening ear. And take times to complete the tasks of the grief process. And I'm going to give you a 3-step task here as we go on what the grief process is.
Before you go on, can I say one word?
Absolutely.
So the personal sense of spirituality too, just keep in mind that if somebody said, what like a bad point, like what church do you go to? And they say, oh, I don't go to church. And then too many people assume, okay, well, they have no spirituality, we're going to ignore that then. But that's not true. So just assessing spirituality apart from
religion
tradition. So
perfect. All right, so as we all know, grief is a process. Rarely does grief begin at Mike, can you double check, make sure we're up?
Yep.
So grief is not orderly or predictable in any shape or form. We got the Kubler-Ross hazard stages of grief, right? and people probably hit those, but we don't know what stages they hit them in. When our chaplain team, our social worker team is working with people through the grief process, we refer to it sometimes as grief work. No one just gets over it. But we kind of learn how to live with it, live with that loss, and move forward. So when we look at our losses, we talked a little bit about the pre-bereavement loss. Charlie, what kind of losses are you looking at when you find somebody with a serious illness?
Loss of independence.
Loss of independence is probably the biggest one we think of, right? What else?
Loss of control, or this idea of control.
Loss of control. You'll find the loss of health. So sometimes we're going to find our cancer patients with a sudden loss, right? Our Alzheimer's patients, they've been through this grief process 5 or 6 times before they ever get to hospice or palliative care, right? And it's different losses all the way through. Changes in roles. So, we got a lot of good husband and wives that can tag team, and they got to flip their roles sometimes, or roles from son and daughter to caregiver for the mom and dad. Those types of things can cause our losses, sometimes losses of jobs and things like that. I got one daughter that lives full-time with their mom and dad while her husband continues to work, and she gets to see him once a week. And I've encouraged a facility, but she's a dedicated daughter. So when you look at grief, it's an emotional response, right? It's how we feel. It's how we feel that. It's individualized and personalized to that person. Those responses are different, and it's also what makes that real or perceived as we look at somebody else. Mourning is that outward expression, that social expression, and mourning can take a lot of phases, right? Or a lot of different pictures. So what kind of mourning have you guys seen? Maybe the spectrums. There's professional mourners, right? There's people who make a living on being a professional mourner at funeral homes. So from that perspective, what other kind of things have you guys seen? I'll use that as one extreme.
I think too many people have apologized to us for showing emotion when we're with their family or admitting.
Okay.
Like they cry and like, oh, I'm sorry. Like it's just like cultural expectation that you don't, show emotion maybe at all in front of strangers.
Okay. So more stoicism, like I can't show this.
Yeah.
Yeah.
So just giving permission to, so emotion's okay.
Yeah.
Not a sign of weakness.
Not a sign of weakness. All right. So bereavement includes grief and mourning, right? Taking those inner feelings and then those outwards expressions of those feelings. When we're looking to take care of our patients on bereavement, we sometimes encourage them to talk about the death, especially for those that have a death where we couldn't make it a good one, right? We want to talk through that. And sometimes families need the physiology behind that death, and why it didn't look peaceful and calm. Sometimes it's helpful to talk through that with the bereavement coordinator, but also with the clinician that perhaps was there kind of talking through physically what they saw. To JD's point, understanding that the bereavement feelings are normal. I don't think anybody can tell anybody else what's normal for them. Allow significant time to express the grief. And then if we can, we solve the practical problems, right? The immediate practical problems. And that may be that clinician coming in and saying, okay, here's what's going on and this is why. I can think of 3 or 4 families that we've done that for in a year, where I go visit with somebody and we talk through the physiology of the death. And that's what the family needed to help.
How much do you talk about the safe and unsafe bereavement? Safe meaning they have a place they can go cry and they have tears and they show anger and they show that kind of stuff. But when they start relapsing on
I got some room right up here for you, Brandon. You're gonna help me with this. Come on up.
Bring your chair.
Bring your chair, buddy.
So Brandon was talking about safe and unsafe bereavement. I don't think we could hear him on the recording, but the safe bereavement being a place where he can share feelings and emotions effectively. And what was the unsafe part?
I've had patients, family members that have relapsed on alcohol that they had been clean from for 6 years, 8 years, 10 years, and they've reverted back to unsafe grief, ways of managing their grief and pain and frustrations. So there's unsafe ways of going through bereavement, and I think that's important to really get a hold of as soon as you possibly can.
Okay. I want to take maybe 5 minutes, and if anybody's willing to share a personal story, I kind of shared a little bit of mine a couple weeks ago, but I may share it again, share the details of it. But I'd like to hear, is anybody have I think all of us are in hospice and palliative care or healthcare for some kind of reason. And sometimes those reasons are personal. Does anybody have an experience that they want to share? I won't let.
Well, it's not my reason for being here. I've expressed that many times. But when I was 19, my mother got stomach cancer. And I was in the military at the time. And so I got to do, they give you the one leave to go home and see her when she was still relatively healthy. And because she was relatively healthy, I didn't really start my bereavement there because we were still able to converse and everything was normal. And then when she actually passed and I went home and it hit me, I went into Unsafe. I crawled into a bottle for 6 months.
Okay.
And just, I couldn't, even after I started doing safe bereavement, it took me a good 20 years where I could even bring up this story without breaking down. And even right now, I'm feeling myself starting to,
Yeah.
It's a very intense process. And I try and bring that to everything I do, that for these people, for me, I've been doing this long enough that while there's still patients that touch me, what it is to me is never going to be what it's going to be for the families.
Mm-hmm.
I can't come close to how that feels for them, and so I try and be respectful of that regardless of which process they're going through.
So good.
Perfect.
Thank you, Sherry.
And so for mine, for those that don't know me well, so my mom was a nurse for 45 years. 38 of those years, she was a DON of a hospital, of the same hospital. And so when I started my hospice path, her first thing to me was, just so you know, you're gonna have to wipe my butt. And when I'm going, I want a lot of Dilaudid. So we took care of the wiping butt part. But as she was, so I was going back and forth between Utah and here. And that last day I flew back just because my brother said something. He's like, we're okay, but her breathing's a little bit off. And that's all he told me. I'm like, okay, this guy knows nothing about what's going on. So I jumped on a plane and I flew down. And I got there maybe 2 hours before she passed. And when I got there, she was in, she had that flash pulmonary edema. And I'd been doing hospice now for about 15 years. I thought I was pretty hot stuff. I knew it all, right? I could fix pretty much anything. I could not fix this. I could not fix my mom's death. I could not make her comfortable, no matter how much Dilaudid I gave her. And so for me, that hits me on a couple points. One, felt like a failure because that's all she wanted, right? And two, it was still hard. She's your mom. So, and that directs how we do things, right? When we have those moments, whether it's our personal experience or a great patient experience that we get to have every day, those affect how we do things better next time, right? Or how we empathize next time, things like that. So our personal grief, our personal stories can help affect. Don't go as far as my one nurse that did the Celtic chanting. We'll back off that just to be a good presence there, and knowing a little bit, empathizing a little bit on what they're going through. So anticipatory grief before the loss. And that's, we talked a little bit about independence and some other things, but also there's that fear that comes along with that, right? And again, hospice has always been the place that I've just loved. But I've come over the last 8 years, I've developed this true love for the house call piece, because I get to see these Alzheimer's patients 5-6 years before a hospice ever meets them. And so, but the downside of that is I see this anticipatory grief and this fear happen at every single stage of life. And it's hard helping families come through this. I'm glad I get to be there, but it's hard to kind of say, this is okay, this is normal. And they're like, this is not normal. I promise you it's okay. So helping them get through that has just been awesome. So the loss of independence, we talked about that. On here, there's the loss of a body part. So if a lot of times we'll see people with gangrenous limbs that are amputated, not resolved, still have to come on hospice. So not only are they losing their life, but they also just lost a limb, things like that. And financial stability kind of goes out the window sometimes with these illnesses. Loss of choice. My biggest statement when I see a new patient on hospice is, you got to understand you're in charge. We are here to guide, we are here to help, but at the end of the day, every decision is yours, and anything we can do to help that decision is the way it's going to be. You get the choice. If they're coming out of a hospital, maybe they didn't get those choices. Hospitals are great trying to help them, but sometimes you just don't get a choice, right? You're in the ICU, there's one visitor, that's your choice, or no visitors based on what's going on. When you look at kiddos, the grief that kids can go through we have to look at, if we go back to school and probably pull up our old school books and look at their developmental stages, right? Because we have to understand developmentally where they're at. If a child was mad at his mom one day and said, I wish my mom would die, right? Or I hate you, then that goes into, well, their mom died a week later. Was that my fault? Right? So those types of things, we got to understand their developmental age so we can talk through it with them. Kids are going to have that fear of abandonment, fear of contracting the disease. So I don't know much about cancer, but is it contagious? You know, sometimes anger, withdrawal, acting out. And then you can see a lot of, and we've seen this in our own practice, that schoolwork kind of starts to fade a little bit, especially in these protracted diseases. And that's usually where we'll see the first wing straight A students go to not, and being able to help them through that process. And then developmental regression. For instance, you know, you've cleared that bedwetting phase and then you regress back to that. Those types of things can happen with kids in grief, and it's all something that we need to look out for when we're taking care of these young families. So there is no normal grief, but we'll call it uncomplicated grief. How's that? So we have 4 levels of care plans in our bereavement plan, right? There's uncomplicated things. We anticipate them doing well. We'll check in with them. We'll make some phone calls. We'll keep up to date and see if they need anything, all the way down to level 4, where we're referring to specialists. We're helping them access resources that maybe you're going to need to help them with those complicated grief issues. So when you look at normal grief, you're still going to have a physical, emotional, a cognitive, and a behavioral component to that grief, whether it's normal or not, right? There's going to be some piece of that of you that's affected by that death or by that loss. There was, you know, sometimes how people do studies just to state the obvious. You guys ever notice that? So there was a study done down in Texas, and they followed hospice bereaved families for 2, 7, and 13 months. They used the Hamilton Rating Scale for depression, the symptom inventory, and the Texas Revised Instrument of Grief. So depression was highest during the first few months, and symptoms persisted up to 13 months. I think that's kind of what we knew, right? And so it just validated with the research. So that's why we do 13 months of bereavement, and sometimes a family needs us longer than we do longer because that's what they need. When we look at chronic, delayed, exaggerated, or mass grief, like when we look at, I'm going to go delayed first. I gave the example of that Air Force pilot, helicopter pilot who had his door gunner shot out of the helicopter, right? Those traumatic events can really make that grief delayed. And when you look at taking care of a veteran, that loss on the battlefield is going to be just as fresh 40 years from now as it is today. And so, and that maybe even if they did do all the right things and they did work good and they did their coping skills, that immediate loss of that battle buddy can be fresh for the rest of their life. So, you know, with this case, you know, that was the only time his daughter had seen him cry. When you look at chronic grief, it's not that it's wrong or inaccurate, it's just that this grief is holding on longer. And you may see that in a husband and wife that's been married for 60 years and 10 years later, the wife is still looking at pictures, not that it's grief, but that's how she's holding on, right? Talked about delayed grief, and that may be a conscious or unconsciously avoid that pain of loss. So either you don't want to deal with it or your brain is like, you don't want to deal with this. And so something's telling you we're not dealing with this until later. And sometimes later is at the time of death. And then we're trying to unpackage 50 years of grief in 2 months. Exaggerated grief, that's where it kind of goes into the thoughts and emotions and behaviors, right? So you have your nightmares, delinquent behaviors, phobias, abnormal fears, things like that. Thoughts of suicide, maybe. Masked grief is where the survivor is not aware of the behaviors that interfere with normal functioning. So I always like to pull out something called Johari's window, where you have your what you know, what you don't know, what you don't want people to know, and then what you don't know and what people don't know. Kind of a 4-box thing, maybe from social work school. And so when you're masking your grief, either intentionally or unintentionally, but other people can see what's going on because of the way you're behaving. We've had that off and on for team members for as long as I can remember, right? I know you're saying you're doing okay, but you're not. So take a minute, take a day off, take a week off, come back next month, whatever it is, right? So sometimes people around you need to instruct you on what you need. So when you look at complicated grief, and this is where we kind of get into our referral outs when we're doing bereavement, you're looking at severe isolation, violent behavior, suicide ideation, workaholic behavior or alcoholic behavior, to Brandon's point, severe prolonged depression, replacing the loss of and relationship quickly. And that may, it's probably think of 5 things off the top of my head where, you know, husband or wife died and kids are like, how are they dating already? It's only been a couple months. It's like, that's them trying to replace that hole in their heart, you know? Avoidance behaviors, and imitating the deceased. So when we look at complicated, this is where we have both chaplain and social worker involved. This is where we have therapists involved, and we really try to get them to the point where they can. And these can happen with traumatic deaths, and we see those often, right? Where the death isn't peaceful, it's traumatic. We need to try to walk people through that. Suicide or homicide, an abnormally dependent relationship. We see a few of those every once in a while. chronic illness, death of a child. And then when you look at, I think it was Chaplain Tim that mentioned the types of loss. So multiple losses all at once, unresolved grief from prior losses, concurrent stressors. And when you look at any of our patients, you can probably look at least half your caseload and say, okay, well, this person lost their dog. They probably lost their cat. They lost their independence. And then all of this is coming together to hit us now. So all things to go through. So when we look at that, we try to find, if we can find a social support network, but a lot of these people that are having a hard time don't have that support network, right? Which is why they're having it. They don't have those coping skills that there's a great man named Chaplain Jack. He lost his wife. And I remember him at the funeral. He's like, I forgot how to do my clothes. And so he's pulling his shirt out, trying to iron it, and it stinks a little bit, but it's funny how you become so dependent on, not dependent in a bad way, but you become a team, right?
Mhm.
And sometimes when you lose that other half of the team, you're like, I don't know what I'm doing. I promise you, if Mary died, I would be completely lost. I can't even show up for classes that I'm supposed to do every week. So,
We got your back.
thanks, Brent. So when we disenfranchised grief, that's one that can be a cultural, that can be a psychosocial, that can be a lot of things that we need to make sure that we identify beforehand, right? And we talked a little bit about gay partners that may not be included in the family structure. And so how do we take care of them? Ex-spouses, it's especially Army guys, military guys, right? Navy guys, their ex-wife from the military is going to come pop back in. I don't know why, but it's like I went through the military with them. I'm taking care of them now. I said, he hasn't seen you in 20 years. Like, doesn't matter. I'm here. All right. So those types of things can pop up towards the end of life. It's funny, the notes in here, mistresses, right? We can't forget to take care of the mistress.
There's another interesting aspect of that when the care team, and they're invested in serving this person, but then the stakeholders in this make a decision ethically or morally that's different. I think of like some of the abortion issues.
Sure.
And so, but this whole medical team has been focused on caring for the situation. Then the parents make a different decision. That disenfranchised grief can be there on the part of the caregivers.
Okay.
And where do they express that? Their personal beliefs and their personal ethics. They're still serving, they're following the wishes, but it's kind of an interesting piece as well.
It's hard to manage on the provider standpoint.
Right.
Perfect. Thank you. So we talked a little bit about children's grief. We need to make sure we understand their developmental ages. We're lucky enough to have a pediatric ICU nurse with our team and a couple other people that have done that. So they understand those a little bit better. But when we look at the symptoms of grief in younger children, so some of the things we want to look for is nervousness, uncontrollable rages, frequent sicknesses, accident prone, rebellious behavior, hyperactivity, nightmares, depression, compulsive behavior, memories fading in and out, excessive anger, excessive dependency on remaining parent, reoccurring dreams of wish filling, denial, or disguised anger. And then for our older kiddos, we look at difficulty concentrating, and that's where the school can come into play. Forgetfulness, insomnia, sleeping too much. And that's hard to tell with a teenager, right? Get out of bed. Reclusiveness or social withdrawal, antisocial behavior, resentment of authority, overdependence, regression, resistance to discipline, attempted or talk of suicide, nightmares, symbolic dreams, experiment with alcohol and drugs, depression, secretiveness, sexual promiscuity, staying away from home, and compulsive behavior. So we had the privilege and honor of taking care of a young family with 6 kids, and they ran the gambit of developmental stages, right? And so is there, for that care team, do we? Yeah.
I didn't get that. Could you try again?
Did not say that. What, did you notice any of this in the kids?
Yes.
What ages were you worried? Are you worried about now?
So I never worked really with the little kids. I worked with the teenagers. And I think my biggest concern is with the oldest teenager, sleeping all the time, just really kind of disconnecting, not connecting with her therapist. There's like anger at her therapist. And I think with that family too, there was a lot of education with the dad with what's normal and what's not, because some of the stuff was normal. And I'm like, yeah, their mom's dying, like that's normal. And some of it, you know, and so just empowering families to be like, you don't need to worry about every little thing. Let's figure out what we do need to worry about and address it, and maybe let the other stuff go.
Sure. And if I remember right, for my visits with that family, the daughter was never involved in my medical visits. Crystal, did the kiddos ever come in with you?
She did, the oldest daughter, towards the very end, started taking an interest and would come in and ask more questions.
Okay.
She definitely withdrew quite a bit and slept most of the time.
And the other thing that I noticed is that the parents and grandparents had a perception on how they thought that their kids should go through grief.
Mhm.
And so that's something else that you have to work through.
I was just going to say something about that. Last night I made a visit and I asked how the 3 youngers were doing, because that was mother's biggest concern, is that their kids won't be able to handle it. They're going to freak out. They're going to have the most difficult time. And when I went over there, I said, how are they doing? He says, I'm actually kind of scared because they're doing really well. And they just built it up that they were going to have the worst grief. And it was going to be the violent grief. They were going to yell and scream and run around. He's like, they actually haven't been that way. And I said, you know, it's just good to be aware that could potentially happen.
Mhm.
But, you know, they're in a period right now where they're working with you. They're working as a team together. Because that's the way he's looking at it, is, hey guys, we're a team. We're going to get this done. And the little things, I mean, they've got a house cleaner that comes in now because he's like, I don't know how to do this. You know, and he's learning how to do this, but he's like, we're a team, we're going to do this together. And the young kids, they feel like they're a part of something bigger than themselves.
That's cool.
That's really cool.
Any other thoughts with kiddos?
I think, just from a personal standpoint, because I lost my father when I was 13, but my youngest brother got over it a lot quicker than my oldest brother did.
Okay.
And my oldest brother, you know, turned into drugs and stuff like that. So I think it's just, I think the younger you are, they really do deal with things a little bit differently. And I think they just kind of tendency to just kind of grow out of that grief phase.
Yeah, maybe.
Just from my own personal standpoint. So.
Well, and I think as you look at a big family, right, you may have looked at your younger brother and say, well, why is this so easy for you? Because this is terrible on me, right? And so maybe that's something like the oldest daughter is, why is this so easy for you guys? We just lost our mom. We should be this, and this.
There's a lot of projection that happens
Yeah.
from the parents, from the siblings, and I think that's something we need to really be aware of, because it can become very toxic. And so just educating and being supportive.
When you talked about that, I thought of this idea of the role of expectation of what grief is going to look like, good or bad, for children and also for adults. I think a lot of adults have an expectation of how they think they're going to process through the grief or how quickly they're going to process through it. With the kids, it's exacerbated by the parents may have expectations, and also just the uniqueness of those children, right? Those children are still deciding who they are, and they may have unique things that change the way they grieve. When I talk to a person in the pre-bereavement who's very expressive and suddenly they shut down, well, there's something there, right? Because what's causing you to not? But with children, I feel like they're really fluid in who they are.
Mhm.
And so my expectations are going to change and probably need to be held loosely with a child, because that could change. That could be something, like that, where if a younger child who maybe is a little bit more attuned and perceptive may pick up on the grief of their siblings and carry more of it,
Yeah.
even though they're younger. Versus, I'm more like, oh, this is fine, everything's great. I might be the older sibling appearing fine, but something that the surface. So when you said that about expectations, I think that's so key that we hold those expectations loosely in grief, but especially with kids, because I think they can pick up on that, and then that changes who they are and their grief. And that's just, there's a lot of moving parts there with kids.
Yeah. A couple other points to think about with kiddos, right? So we had an infant on service, right? And his parents were kids.
Yep.
And so mom's awesome. She's a rock star, but, and he, he's eating, and he came off hospice onto palliative care, and we're taking care of him over on that side. But, the grief that was there, the family kind of came together. I thought that was really cool. The parents are supporting these two kids that had an infant. And then, our kiddo out in Kuna with cancer, it's funny when you have the privilege of taking care of a kid with cancer, how strong that child is. And sometimes he or she's the one holding it all together for the family. And so when that loss is gone, it's kind of a collapse sometimes. I don't know if you have any thoughts on what you experienced.
Sure. So I did things with that child and caring for him that I would probably never do with an adult. Like, I haven't sat down and watched an adult play video games as they're dying of cancer. I haven't brought over like different beads of different shapes and textures to evoke some sort of emotional cognitive response by touching something like that. I'm sure that may be a good one for adults. I just haven't done it. But yeah, so just bringing over, laying down a bunch of beads and letting this little guy go through things that, spark interest in him, that makes him think. So, and just the awareness or the difficulty, I think, of just with his mom of like, she's having a hard time, but just like how much you want to lean into that pain to get her to express it without being pushy, like inviting, but not, being encouraging and inviting, trying to find that fine line. But all this comes down to just being willing to be present and to go where they want to go. Yeah.
And the last part I'd talk about kids is, as team members, as the healthcare providers, we have to know when we need to step out or when we need help from somebody else, right? It's kind of, I don't mean to say this lightly, but to make a point, it's kind of easy to take care of an 80-year-old guy that had a good life, right? Mm-hmm. It's much harder to take care of a kiddo that hasn't got started yet. And so that can take its own effects on the care team. And we saw it with this one that JD was talking about. The nurse that was there needed to step out months before she did. And from the care was better when we were able to get fresh eyes and fresh ears in there and take care of him, because we allowed something to go for too long.
And for that too, for me, I've had to do some major work, because as on my way to his house, I would pass my daughter the exact same age, her school. Mm-hmm. Like that was right on the way. I'd pass her school. She was in there healthy, and that took some emotional work.
Process,
sure.
right?
Process.
Yeah. I always go home and have my kids a little bit tighter.
Yeah.
Lauren had some.
And one thing I would encourage is with families too, with younger kiddos, is being really honest with them, obviously like age appropriately, but you also want kids to feel comfortable with that grief and that loss and ask questions and things like that.
Yeah.
So giving tools to the family as far as, these are some things that you can talk about, these are different resources that you can use, but that's a big one that comes up, is like, how would I help my kid? is grandma or grandpa gonna die? Like, what do I say? And so
Yeah.
just giving tools to families to be comfortable to talk to kids about that, so they don't carry it with them and push it.
Yeah, thank you. So 3 stages of the tasks of grief, right? Stage 1 is notification of the shock, share acknowledgement and reality of the loss, and recognize the loss. And this may be where we're assisting the survivor with coping and initial impact of that death. The survivor may have that numb kind of feeling, shock, even if they're expecting the death. When it happens, I can't tell you how many people I said, I thought I was ready for this. And you're just not. There's nothing you can do to prepare for that last breath. Stage 2, experience the loss emotionally and cognitively. So share in the process of work through the pain of loss. Survivor may feel anger at the person who died, abandoned, anger directed at the physician, the nurse, the healthcare team, the family, or friends. Survivor may feel guilt based on perceptions of not being able to do enough. And I think we hear that most days of our week. Survivor experiences sadness, loneliness, emptiness, lack of interest in daily life, some insomnia, changes in appetite, apathy, disorganization. And then stage 3 is your reintegration. Reorganize and restructure the family systems. Maybe your day-to-day systems, like our chaplain Jack being able to do his own laundry again. Readjust your relationships and reinvest in other relationships. And that's where hopefully the survivor's finding hope in the future, feels a little more energetic, participates in those social events, and then hopefully can accept the death and move forward with their lives. Okay, we got 15 minutes. So we got maybe 12 minutes left. So I think we're gonna talk about on this slide probably the most, because I want to talk about coping skills and coping patterns, and then I want to talk about how personalities can play into grief. So I gave our chaplains and social workers a 5 minutes heads up that I was going to ask them questions, but they've had now 45 minutes to think about it. So maybe let's start with, give me some good coping skills. What kind of good coping skills do people develop throughout life?
Talking to their support system.
Okay, so accessing their support system.
Practicing self-care.
Self-care, okay. What can self-care look like?
It can look like anything from, getting out of town for the weekend to take a break from their life, to, reading a magazine in the bath, any of those things that you can do on a daily basis to kind of refill your cup.
Okay.
Go for a walk.
Walks, okay.
Exercise.
Where do coping skills come from? All of us have different coping skills, right? Where do those coping skills come from?
They're learned.
Yeah.
Life experiences, learned, right? Does somebody that has a lot of loss in life, do they have good coping skills or bad coping skills? You don't know, right?
Sometimes great. Some people are born with
Some
resilience.
unhealthy coping skills are effective for a time. Like I think about abusing drugs. The reason people abuse drugs is because it works for that initial to deaden the pain.
Okay.
Long term, that could really, but part of that is those coping skills are there and people use them because they work on some level. So part of that is, I think, when you talked about going back to alcohol, no matter what coping skills they've learned through AA or another to deal with this, that overwhelming grief causes them to go back to a coping skill they have learned.
That they can get immediate relief of that pain.
It's very powerful, causes harm down the road, but right then, that overwhelming grief is going to push them back to that powerful coping skill.
Okay, so some negative coping skills, alcohol, drug abuse, maybe good in the short term,
Yeah.
bad long term. Let's shift to negative coping skills then. So we got that. What other kind of negative coping skills can we look at and identify maybe?
Like somebody who doesn't talk to others very often, like they learn that, by disengaging themselves from everybody else,
that they feel better. And so again, the same as alcohol, it's good short term, it's bad long term because they habitualize their coping skills and that becomes a part of who they are. When
So,
really it's just a coping skill.
so simplifying that is isolation, self-isolation,
Yeah,
and that makes them feel better.
right. Or anger maybe when people talk to them, they just automatically lash out when it's really like sadness.
Because they're throwing up that wall.
Yeah.
Okay.
I just was saying like deflecting humor or like,
Okay.
you know, trying to make jokes all the time when you're like, okay, at a certain point, like you're just trying to distract us from having to talk about this.
Okay. So deferring the conversation to another time. Okay.
Had a
Anger
coworker,
habits.
had a coworker that cut herself on her leg.
Yeah.
Cutting.
So they're, so self-harm.
Taking on a caretaker role. Like I did for my mom, when my dad died, I took over that role as a caretaker, you know, making sure that my mom had everything that she needed.
And so did you bury your grief in that work? I can promise you, if I have grief I can't handle, you'll see me at work from 6 a.m. to midnight.
And I still do that.
Yeah, it's, hasn't killed me yet, right?
I'm stealing Mike's, but he just said, I work.
Yeah.
Like, just like pouring yourself into your job or your work or carrying or folding into a role that's not yours to take, but you just want to have something to do.
Yeah. JD, you mentioned,
An unhealthy relationship with food.
okay. So that can,
Sorry.
Bagels.
there's a lot of carbs in the room right now.
Relationship with the drive-thru worker at McDonald's.
That's your bartender? McDonald's bartender. That's so Brandon, I don't know if we heard it on the recording, but Brandon talked about self-injury behavior. So cutting, right? It can be on the legs. You can see teenagers might do it on their legs instead of their arms because all of us are now trained to look at arms when we're worried about somebody, right?
Yeah.
So now kids are doing it on their thighs.
You got a chest too.
On their chest. Yeah. So it took me a long time to understand that as I was going through my mental health training. It's like, why would you, that hurts. Why would you do that? But that pain is less than the pain they're emotionally feeling, right? And that's why they do it.
And that's the same as anger, you know, anger feels better to people than sadness or grief or pain.
Especially
So-
culturally, right?
Yeah, so that's why that is one of those stages of grief that, you know, are identified as a part of grief because it's easier for us as humans to experience anger than that terrible pain of loss.
Anger is
Yeah.
less vulnerable.
And it's more socially acceptable.
Yeah. So as I'm sitting around the room with a lot of smart people, how many of you take the time to look at your person to your left and right and say, hey, why don't we take a break? Right. And if they're not willing to, maybe you go to their team lead. Hey, they need to take a break. So those types of things are important to look at, right? Tell me about how personality can affect grief and loss.
Grief can often amplify parts of our personality, whether it's strength or weaknesses. All the chaplains and social workers have gone through a grief training by Dr. Joy Samuels, and she has a whole section on personality. And it's called Personality Factors from McCrae and Costa. And it's the big five. It goes ocean. So one is a person's openness to experience. So whether they're curious or cautious. The other is conscientiousness, whether they're organized or careless. Their level of extroversion, whether they're energetic or reserved. Their agreeableness, so whether they're compassionate or detached. And their neuroticism, whether they're nervous or confident. And depending on one of those factors, whether they're more resilient or whether they're more rigid, they'll have a more difficult time with grief or they'll be more resilient with grief.
Awesome. Is that a handout that you have?
It's a slide from the training that we have.
Could you send that to Abby so we could share that with the group?
Absolutely.
So there's quite a few handouts in this, and we'll ask Abby to share it with the group. That's online. Yeah,
I have a good example of like personalities and grief.
please. We may not be able to hear you well. Would you mind coming forward?
This was just a family that Sabrina and I had, and there was 6 or 7 siblings, and the family hadn't had much interaction with like social supports as far as like mental health or things like that. Very well-to-do family. And Sabrina and I sat down at the beginning of our process, and we talked about how different personalities can come through with grief. And all of the siblings are like, oh no, that's not a thing for us. Like, we're all really close. Like, that won't be an issue. And Sabrina and I are like, okay, but these are just some things to maybe look for. Within a couple of weeks, we had one that took on all the responsibility. We had another sibling that just wasn't interested in being involved at all. Some disagreements within the 7 siblings. And so Sabrina and I had to go back out and kind of talk about, this is what we're seeing. Like, how can we help? Do you guys have questions? Like, you're starting to see some of these personalities and roles take place because we're getting closer to end of life. And so
There was some lashing out.
yeah. And it's just, they all at the beginning were like, nope, we're good, and some of them were a little bit more outspoken, some were quiet. And then those roles reversed like completely as we went through the process.
I think it's a lot more common to see disorganization and chaos towards the end of life than a smooth transition, right? No matter how, there's no normal family, right? I'm actually dealing with this right now with my uncle, my mom's brother. The hospice team isn't doing what I would do. And so
they obviously live somewhere else.
And so I was kind of talking to this has always been out of my family, this was the normal family, right? I don't have a lot of those in my group, but this was the normal ones. And it's interesting to see, even when on the outside looking in, I was like, oh, well, these guys are gonna be okay. The oldest son is like, they are killing my dad. I have a hard time not agreeing with him. But the mom is on board with the hospice nurse. So I'm trying to say, well, maybe we give a less than 10 milligrams of Haldol today. Let's just see if he wakes up a little bit. And so I'm kind of texting her. I was like, how did that less dose? Oh, he was talking yesterday. I was, oh, let's try a little bit less tomorrow. So no normal family at the end of life, right? No matter how good your coping skills are and how good you think they are, something's going to surprise you. And so always be available, always be open for that surprise and that fluidity of bereavement, right? The last thing that I would say is there's one other component of our care that we haven't talked about, and that's our facility partners, right? Probably the one that kind of hit me the most is I'm coming into a skilled building. I'm helping the CNA take care of this patient, clean them up, give a bed bath. And we moved them. And when we moved the patient facing the CNA, patient took their last breath. And she like dropped what she was doing. I think she just died and then ran out of the room. And so, I mean, it was a kid, right? She was like 17 or 18. And so I laid him back down, finished what I was doing. And then I went and found that CNA and be like, this was her first, she had never seen this before. And so she, at that moment, was my priority, trying to help her walk through this. I think sometimes we get so used to seeing an abnormal situation, right? We get so used to death sometimes that we just got to remind ourselves that this is, for some people, this is their first time, whether it's a caregiver in a facility, a CNA, sometimes even a nurse, right? Administrator, somebody, it may be their first time going through death, and this may be extra hard on them. So we need to make sure that we look around the room, we look around the facility who's struggling with this death, and include them as, kind of take them under our wing and help them out as we go through our day. And then there's going to be others where it just seems to happen around the valley. Some of these facilities will just get hit with the rash of deaths. And we just have to, I think one facility last week lost 10 on like 3 or 4 different hospices. And so the amount of stress that team is under, you know, we just want to make sure that we connect with them and say, is there anything we can do for you? And whether it's Mike's team bringing some pizza and some coffee, or it's, you know, we've done times where we sat down with our chaplain and social worker and said, let's talk about this, and do like a mini grief group for that team. Those types of things. Just want to make sure that, because we do have the privilege of working in some of these facilities, we want to make sure that they're part of our team from a bereavement perspective as much as it is from a caring for the live resident, right? Okay, I hit my 1 hour. Any questions, any last thoughts?
I guess I'll just say, what kept coming to my mind was the physical manifestations of grief. We can think of grief as purely emotional, but I think it was a couple times ago you talked about spiritual pain showing up physically. And I just think like